Easy, the closed angle glaucomas. Hope that it's clear. A myopic shift because of the ciliocoroidal effusion will cause shift of the iris forward and also shift of the angle forward. They will have relaxation of the zonule. So this relaxation of the zonule will make the lens pushed forward. This will what will result in myopic shift. Okay, so regarding the congenital glaucomas, let's start with the primary congenital glaucoma. So primary congenital glaucoma, everything in this slide asked before in the exams. First of all, mostly sporadic or 10% is autosomal recessive. That's asked before. Sporadic, the primary congenital glaucoma is mostly sporadic. Most cases are, there is no genetical basis. Only 10% are autosomal recessive. And what is the mechanism of primary angle closure glaucoma? It is usually angle dysgenesis. So you can see this is the normal pores or normal openings of the trabecular meshwork, allowing the aqueous to pass smoothly from the anterior chamber to the sinus system, like into the canal of Schlemm and to the aqueous veins, episcleral veins, and so on. This is the normal. However, in those patients with primary congenital glaucoma, they have angle dysgenesis. The openings of trabecular meshwork are not against each other. So this will result in that the aqueous will face some resistance as it will pass from the anterior chamber to the canal of Schlemm, leading to resistance to aqueous outflow. So this is an angle dysgenesis. There is a rule called the rule of 2/3 in primary congenital glaucoma. 2/3 of cases are primary. So most of cases are primary congenital glaucoma. 1/3 is secondary congenital glaucoma. 2/3 are male. 2/3 are bilateral. And 2/3 are diagnosed by 6 months. So what will be the symptoms of those patients? They will have classic triad of epiphora, photophobia, and blepharospasm. We mentioned before in the lacrimal system that epiphora should be suspected as a congenital glaucoma in any child presenting with epiphora. So epiphora, the commonest is the nasolacrimal duct obstruction, and the most dangerous is the congenital glaucoma. So those patients who have high intraocular pressure, the problem or the distinguishing feature in those patients is that they will have large globe. This is what will result in large megalocornea and large globe. This is because the collagen of the pediatric eyes are not that stiff like adults. So it will yield under the effect of intraocular pressure, causing enlargement of the globe. That's why also cupping doesn't occur early, or if it occurs, it will be reversible in such cases, because the effect of the intraocular pressure on the ocular wall is causing stretch of the ocular wall, rather than it will cause damage to the optic nerve in case of adults. Also, this stretch in the cornea what will result in horizontal stria called Hab stria. This also will result in corneal edema, and the greater incidence occurs with later diagnosis. So it will be more common with the older the child. It will take some time to happen. Corneal diameter is more than 12 millimeters. And there is high flat iris insertion, so they will have angle dysgenesis. The whole anatomy of the angle is disturbed here. And it could be that there is peripheral iris hypoplasia. The treatment of patients with primary congenital glaucoma should be surgical after medical preparation. So as we said, that the problem here is the angle dysgenesis. So this we needed to find another or an alternative pathway to the aqueous. But those patients have high intraocular pressure, so we need first to control. There are some important tips here about control the intraocular pressure. Is that you should avoid the alpha agonists in less than 2 years old. I think that we mentioned that before. that alpha agonists in 2 years old will cross the blood-brain barrier, which is not well developed at that age. So it will result in apnea, it will result in suppression of the higher centers. So this is serious and you can kill the child. So we should avoid the alpha agonists less than 2 years old, and we should be careful with the beta blockers. So beta blockers will tend to show higher absorption or higher effect in children more than the adults. What will be then after controlling them by medication? That the treatment will be surgery. So what will be the surgical treatments? It will be, there is a procedure called goniotomy. So goniotomy meaning that we are doing incision by gonio knife, called Barkan knife, into the angle. So we are making like a paracentesis is then under visualization by a direct gonio lens. We are making incisions into the angle by this gonio knife in an attempt to break this membrane, allowing or trying to create a natural opening or a natural passage for the aqueous through this genetic angle. But the condition or the prerequisites in case of goniotomy is that the cornea should be clear. And it is understandable that you need to do this under visualization. So the cornea should be clear in order to pass a gonio knife and to cut the angle. But if the cornea is cloudy, then you can do another alternative pathway, which like you do, like as if you are doing a subscleral trabeculectomy or deep sclerectomy. So you will make a scleral flap, and then you will pass this tube or this knife into the or this cannula into the canal of Schlemm, and or into the trabecular meshwork, and trying to cut the trabecular meshwork from outside. So this is called the trabeculotome. So, sorry, it is a trabeculotome. I said it's cannula. It's a trabeculotome. The trabeculotome, so it will be like metallic, it will be sharp. So you pass it into the angle and you sweep from outside to inside, leading to cutting the angle, trying to make an opening between the canal of Schlemm and the anterior chamber. This is done if the cornea is cloudy. If these measures fail, then you do trabeculectomy, and to increase the success rate, you do mitomycin. And if it fails, usually the most successful measure in these children in pediatric or in congenital glaucoma, it will be the valve drainage devices. So we will discuss this in more details at the end of the lecture. Another form of congenital glaucoma, but it tends to appear at older age. It's called juvenile open-angle glaucoma. So it is a sort of an open-angle glaucoma, but unlike the primary open-angle glaucoma that it presents at older age, above 40, this kind of glaucoma appears in between 4 to 30 years of age. Those patients will have high intraocular pressure and normal angle, so it is called open-angle glaucoma. So that's why we are putting it under the category of congenital glaucoma or developmental glaucomas. It will occur at the early age group. It is autosomal dominant, and it will also present with progressive myopia. Again, it is the effect of the intraocular pressure on the ocular wall. It will cause enlargement of the globe, causing progressive myopia. And for most of those patients will need surgery, and the surgical management will be effective. Now let's move to the secondary angle closure or secondary congenital glaucoma. So it will be usually associated with other problems into the anterior chamber or into the eye, like microphthalmos, like microcornea, megalocornea, cornea plana, sclerocornea. You remember when we said that in the pediatric cornea problems, we said that they could be associated with congenital glaucoma. Also, the spectrum of anterior segment dysgenesis, aniridia, lens anomalies, persistent fetal vasculature, and entropion UV syndrome. So let's speak about the anterior segment. So we spoke about the microphthalmos, microcornea, megalocornea, cornea plana, sclerocornea. Let's now, and we also spoke about the aniridia. Let's now, and today, speak about the anterior segmented dysgenesis. Anterior segment dysgenesis, it has a spectrum of a large number of disorders. One of them is called, or the first one, it's called the posterior imperitoxin. Luckily, the posterior imperitoxin is not associated with glaucoma, but it is just the, let's say it is the most benign category of the spectrum of anterior segment dysgenesis. Those patients have autosomal dominant inheritance, and by posterior imperitoxin, we mean that there is anteriorly displaced Schwalbe line. So the Schwab's line shouldn't be visible by direct slit lamp illumination, like here or here, but however, it is prominent and it is visible. This means that it is thickened, and also it means that it is anteriorly displaced. You can see it under the slit lamp as grayish-white Schwab's line, concentric with and anterior to the limbus, like that. This can occur as like a separate anomaly or a separate finding. Usually it doesn't cause any problems. Or they could affect or could occur with the Axenfeld-Rieger syndrome, or could occur also with arteriohepatic dysplasia, what's called Alagille syndrome. So it happens with those two syndromes. So what I want to stress here is posterior imperitoxin happens in this case. There is anterior displacement of the Schwab sign. So for the MCQs, they will tell you posterior imperitoxin occurs with posterior displacement of Schwab's line. No, it is anterior. So posterior imperitoxin with anterior displacement of the Schwab's line. So if I were you, I will ask, okay, this is posterior. So what is the anterior imperitoxin? The anterior imperitoxin, there is congenital widening of the corneal limbus. So the limbus itself is becoming wide. Okay, so this is called the congenital or called anterior imperitoxin. This can be differentiated or should be differentiated from arcus senilis, arcus juvenilis. But this is not the line in front of the limbus, but it is just the whole limbus is widened. Okay, this is called anterior imperitoxin. There is another anomaly that belongs to the anterior segment dysgenesis. It's called Rieger anomaly. In Rieger anomaly, this is a congenital ocular defect causing by anterior segment dysgenesis, where there is a severe anterior chamber deformity. There is prominent strands and marked atrophy of the iris stroma. So you can see that the iris stroma is severely atrophied, with hole formation and pseudo hole formation and correctopia. There's displacement of the pupil. So this is called Rieger syndrome or Rieger anomaly. In Rieger anomaly, there is just ocular affection. If we combine both the posterior imperitoxin and Rieger anomaly together with other systemic association, then this is called the Axenfeld-Rieger syndrome. In the Axenfeld-Rieger syndrome, it also belongs to the anterior segment dysgenesis, and it is a bilateral disease with usually symmetrical. It is autosomal dominant, and 50% of cases will be associated with glaucoma. There is a problem in the neural crest development, and there is posterior imperitoxin, and there is iris hypoplasia, like Rieger anomaly. There is correctopia, and there is also systematic associations. The systematic associations will be like periumbilical skin redundancy, pituitary abnormalities, teeth and facial bone defects, like that. There will be also like broad nasal bridge or flat nasal bridge or maxillary hypoplasia. So these are some systemic manifestations. So again, to summarize the Axenfeld-Rieger syndrome, there is posterior imperitoxin, there is iris hypoplasia like Rieger anomaly, there is systemic manifestations like in the facial bones. So I brought this teeth because for those of you who are going to apply for the FRCS3 or the final FRCS or FRCF, this case is very common. They love it. They love the Axenfeld-Rieger syndrome. And the key to diagnose it like for the first instance to look at the teeth of the patient, this wide separation of the teeth. And when you see on the slit lamp, you will find the posterior peritoxin with the iris hypoplasia, so you will reach a diagnosis. So this sometimes they believe it is hard to diagnose, but actually if you are minded about it, you will diagnose it very easily. Another condition that also occurs due to anterior segment dysgenesis, we spoke about it before, it's called the Peters anomaly. Peters anomaly, it is an autosomal dominant or recessive, but usually it is sporadic, and it is characterized by central corneal defect. So there is a central corneal defect. There's a defect in the posterior stroma, desmids, and endothelium. So this area of the central cornea doesn't have any underlying posterior stroma or desmids or endothelium. That's why it is opacified. So there will be a central corneal opacity, and usually the iris will be attached to it. It is usually bilateral in 80%, and 50% of those patients will have glaucoma. So you see the number 50% is very common here. 50% of patients with eyes have glaucoma, 50% of patients with Axenfeld Rieger anomaly, 50% of patients with Peter anomaly. So you see 50% here is a very common number. There is another plus disease, or let's say it's called Peter plus syndrome. In Peter plus syndrome, it is autosomal recessive, characterized by defects into the anterior chamber and systemic abnormalities. So the Peters is that just ocular, and it could be autosomal dominant recessive or sporadic. The Peter plus is only autosomal recessive and has also other systematic abnormalities, such as heart abnormalities, ear, palate, and spine problems. Another case also of the anterior segment dysgenesis, we talked about it before, is the aniridia. So we said before that there is bilateral absence of the iris, but it is more commonly to have a rudimentary iris stump, which will rotate and close the angle, resulting in secondary angle closure glaucoma. It is related, it could be hereditary or sporadic, as we will see now, and it is mapped to chromosome 11p13 or PAX6 gene. Has three types. It has three types. The aniridia type 1, which is the most common, it is autosomal dominant and only affect the eye. Aniridia type 2, which will be the less common, it is a sporadic and could be associated with Wilms tumor, in which there is a Miller syndrome and Weger syndrome. So the Weger syndrome is Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation. So that's why those patients we need to send for abdominal ultrasound. We solved MCQ on that before in pediatric ophthalmology. Aniridia type 3, it is the least common. It is autosomal recessive and it can be associated with mental retardation and ataxia, what's called the Gillespie syndrome. Those patients will have poor visual acuity, foveal and optic nerve hypoplasia, nystagmus, photophobia, due to the hypoplasia of the optic nerve and the fovea. Amblyopia, of course, and strabismus. Could have cataract in 50% and the glaucoma also 50%. So again, number 50% is common in those patients. Ectopia lentis and corneal pannus. Finally, the other cause of glaucoma or cause of secondary angle closure glaucoma, it could be due to phacomatosis such as Sturge-Weber syndrome. So you remember when we spoke about Sturge-Weber syndrome, we said that those patients have high episcleral venous pressure because of the choroidal hemangioma, so there will be blood in the canal of Schlemm, and there will be resistance to the aqueous outflow. This will result in will result from increasing the episcleral venous pressure. That's why the doing angle surgery will not be beneficial here. But on the other hand, it will cause increasing incidence of suprachoroidal hemorrhage. And 50% of those patients will develop glaucoma. So again, 50%. And congenital glaucoma can occur either from angle anomalies. Those patients could have angle anomalies, or due to increasing episcleral venous pressure. The neurofibromatosis type 1 patients, those who have this plexiform neurofibroma of the eyelid, again, they will have glaucoma caused by either congenital anomaly by the angle, with or without ectropion UV, or it could be there is angle neurofibroma. There could be some neurofibromatosis at the angle itself. And also, by the way, it can also occur in 50%. Okay, so you see 50% is a fixed number.